nose test side. Okay.
Sorry, I couldn't hear you.
Finger nose test. When you perform the finger nose test, it is
Yeah.
positive on this side. It tends to pass point. So
Okay. So
now we move on to the radiology. Can we have the radiology, please?
So these are the findings.
No, but so smart.
just give me a minute to go through the findings quickly.
Yeah, sure.
Okay. Okay.
So,
Yes,
so what
Pranav,
would you
can we
like
have the
to?
radiology?
What kind of
Yes.
radiology would you like to do?
I would like to get an MRI brain plane with contrast.
Okay. Now, can you
Uh,
explain this MRI, please?
yeah, sure. So these are MRI brain plane with contrast. Two of them are axial sections. The last one is the coronal section, showing the posterior fossa region along with the middle cranial fossa. And in the posterior fossa, we can see a hyper intense lesion in the left cerebellum,
Hmm.
and which is compressing the midbrain, which is compressing the brainstem and also causing midline shift in the cerebellar region as well. It is compressing the fourth ventricle as well. On post contrast images, we can see that there is very subtle enhancement around the periphery. It could be a mural nodule as well, along with the cystic component. The cyst walls are non enhancing completely. On coronal sections, I can see that the lesion is within the cerebellum, but it is close to the tentorium. And yes, there is a contrast enhancing mural nodule.
So, what is your diagnosis?
Given her age, do I need to tell the diagnosis or do I need to give two differentials?
Because we don't have the patient, so yes, give me differentials. Give me two differentials, and then tell me one diagnosis.
Okay, my first differential would be pilocytic astrocytoma because there is a large non-enhancing cyst with a mural nodule, which is a typical finding for it. My second differential would be pleomorphic xanthoastrocytoma. No, sorry, I'm sorry, I take that back. My second differential would be hemangioblastoma because again there is an enhancing mural nodule.
Yes, but hemangioblastomas tend to have a significant enhancement, and this is not uh, fitting into that criteria. It's
Uh,
okay.
okay.
Whenever the examiner asks you that what do you think it is, give me your differentials. So it
Mhm.
is not always necessary that you give minimum two or three answers. You can
Okay.
give only one answer if you think that fits. For example, you say that this is pilocytic astrocytoma, and I would not put any other lesions such as I had some other lesions in my brain, pleomorphic astrocytoma or hemangiopericystoma, but because of the answer, I don't think that is
No,
good
sir.
enough.
Hemangioblastomas also present
Yeah,
like this. No,
yeah,
having.
but you can always say that these are not exactly fitting into the scenario. So I would
Okay.
keep my differentials to most likely polycytic, which you did.
Okay.
So don't try to unnecessarily add differentials, but you
Okay.
did the right thing. And
Okay.
two differentials is more than sufficient. And whenever
Okay.
you are saying differential, give your inclination that yes, it is more likely pilocytic. So I think you
Okay.
did the right. So yes, it. So we say that it is pilocytic astrocytoma. What would be
Okay.
your subsequent management?
Okay. After adequate counseling and assuming that we are done with the history examination and baseline investigations and anesthesia fitness, my plan would be to go for surgical resection in this patient, and I will counsel her that this is most likely a low-grade pathology. So, do you want me to name the surgical procedures?
Yeah, just name the procedure. That's all.
Okay, so this I would go for a complete resection of this lesion via paramedian suboccipital craniectomy.
Agree. Shabash. This was a nice explanation, and you did very well. And if this was a real patient, then I think you would have scored definitely full marks, probably full marks. Good job,
Thank you, sir.
Kamal.
Thank you.
So, Dr. Yusuf, uh, would you like to comment about this case that as a whole? For example, if this case comes in the long case. So,
Mhm.
how will you help
Yes.
them regarding the management, maybe, and even in the shorter, short case as well, talking about the differentials and then management and what they can
Mhm.
improve as a whole.
I think Kamal, right? Yeah, Kamal did a very good job, and she ticked all the boxes, all the specific examinations. It's just that whenever you are performing this on the patient, remember to go in a sequential manner, because sometimes you might speech, then you will go on to the heel shin, and then you will remember this dysdiadochokinesia, so you'll go, and then you'll do the finger nose test again. Then you will, so don't keep on going from top to bottom, from top. So these are common cases now. Hardly, if you make a list, there are usually 10, 15, 20 cases of short cases. So just practice examination of cerebellum so that you do it in a sequential manner. Just keep that in mind. Otherwise, all the things that you mentioned, they were completely right. And in terms of radiology, yes, she explained the radiology also quite well. Although the lesion is not abutting the brainstem, it's a little bit far, quite far, and we don't have any proximal scans which could suggest proximal hydrocephalus because the scans were not included. But other than that, she did a good radiological assessment. Plus, as I mentioned earlier, that this only fits in the criteria of pilocytic, because even hemangioblastomas are usually do not present like this. But yes, she kept the differential to minimum. So she did not unnecessarily add any differential. So I think this was a very well prepared and presented case.
So how will you differentiate between the two, Dr. Kamal? Would you like
Uh,
to do any other investigation?
in this patient, yes, sir. Um,
No, I mean between the two differentials you are talking about, pilocytic and meningioblastoma. How would you confirm that?
um, I'm not sure, sir.
So
Okay, generally,
the confirmation will be on biopsy based, on histopathology based, but we
no.
can
I
do.
mean, we're not talking about the
Yeah.
histopathology or surgery before the surgery. Is there
So
anything that can help you?
yeah,
Sir,
so
on
we can do angiography. So if it is
Yeah.
hemangioblastoma, so that will be like there will be quite in increased number of vessels, because then
Mhm.
we need to resect the lesion like avium. The solid hemangioblastoma needs to be resected on the principle of the avium. So that can help. Another thing in hemangioblastoma, because in 30% of the population it is associated with the von Hippel-Lindau syndrome. So then the other investigations are also important to rule out that, like the ocular examination for hemangioma or hemangioblastoma, and
Yes.
yeah, and the
So coming
CT
back to
tab, CT thoracic abdomen and pelvis, and these things are also because the renal component and the pancreas and everything.
okay, doctor. Okay,
Yep.
Dr. Abdul, let me ask Kamal another question. So, Kamal, talk about the cyst. I mean, how will you treat them differently? I mean, mesoblastoma and parasitic astrocytoma. If you're treating them surgically, what's the difference between the surgical management?
sir, if the cyst is contrast enhancing on the pre-op imaging, I would like to go for a complete cyst wall
So,
excision.
for example, it's not enhancing
Yes, sir.
on
This
both
is
the
not
lesions.
enhancing.
Now,
And
दोनों lesions के लिए नहीं कर रहे हैं.
okay, sir, this is not enhancing, so I would leave it back because trying to take it out completely might increase the morbidity in the patient. And since it's
How?
non-enhancing, sorry, sir.
How will it increase the morbidity? It's causing the mass effect. So
Sir, once we take out the mural nodule and we aspirate the cyst, the mass effect is going to end, and there is uh, down to 0% risk of recurrence if the cyst is non-enhancing and we have taken out the mural nodule.
In both cases?
You're talking about hemangioblastoma?
No, I am asking you, अगर दोनों
I am not
differential
sure.
zone,
I am not sure
difference
about
है
the.
उसके अंदर.
I am not sure about the hemangioblastoma, sir.
Dr. Yusuf can guide about the management as well.
Yes, for hemangioblastoma, also you have to just completely remove the vascular nodule, the feeders, and just you have to go around it, as one of the candidates mentioned, and that's all. You don't have to again go around the capsule or anything as such. You just have to take the vascular lesion and go around it. That's all.
Okay, sir.
Yeah, because the reason के वहाँ पर जो AVM kind of वो होता है hemangioblastoma, तो उनकी जो vessels होती है वो leaky होती है, and just because of that leakiness वो जो cyst बन रहा होता है. So if you remove the nodule, that will be more than enough. ठीक है, आपको cyst को कुछ भी करने की जरूरत नहीं है. But in pilocytic astrocytoma उसके अंदर generally आपको decompress करने की जरूरत पड़ती है. और अगर वो enhancing है तो then you aim to remove the wall as well as much as you can. ठीक है, so वो उसके अंदर है. Or similarly, the cyst is very important for the surgical planning as well, because it can guide you to the lesion. ठीक है, और generally ये भी होता है कि आप उसको guidance तो लेते हैं, but you do not decompress at the start, because आपको nodule find करना होता है. अगर decompress आपने कर दिया तो nodule will shift its location. So वो भी helpful होता है इसके अंदर. जिस स्पीड हम थोड़ा सा डिस्कस करें ताकि जस्ट इन केस अगर ऐसा कोई केस आपके पास आता है तो यू वुड बी एबल टू आंसर ऑल द क्वेश्चंस. किसी ने कोई और सवाल करना है? For I mean, we have one
अच्छा,
more
एक और
minute
चीज,
and then
ये किसी कैंडिडेट से ना डॉक्टर खालिद महमूद ने पूछा था कि भाई सिस्टिक ट्यूमर है, ये पुरानी बात बता रहा हूँ, आप कैसे फाइंड करेंगे? तो वो फिर बाद में पता चला, वो सुनना चाह रहे थे कि भाई अगर सिस्टिक ट्यूमर है ना तो आप उसमें डैंडी डाल दें, तो ताकि आप एक दफा सिस्ट में एंटर हो जाए, एंड देन यू कैन जस्ट फॉलो इट. उसको एक दफा सिस्ट में एंटर हो गए तो फिर नोड्यूल को आइडेंटिफाई कर ही लोगे सिस्ट के अंदर से. तो ठीक है, तो the best option is not always to rupture the cyst, but you can rupture it as you enter it. अगर पहले रप्चर हो गई फिर उसमें नोड्यूल, जैसे फरूक ने बताया, मुश्किल हो जाता है. कुछ नहीं तो आप उसके अंदर एक ड्रेन डैंडी कुछ डाल दो ताकि बस आपकी सिस्ट लॉस ना हो.
yeah. Okay, so we can move to the next case. There is some technical problem with the live streaming today. I mean, I'm unable to connect to the YouTube. So if everyone is comfortable, let me just stop this meeting here, and we can reconnect just in case if it's possible for everyone. तो मैं फिर जो है वो हम दोबारा से एक बार try कर लेते हैं अगर live streaming हो जाती है, because there are a few candidates. I don't know for what reason, but they are just looking, I mean, watching the live streaming and not joining here. So I'm just stopping this meeting, and you guys can reconnect in like 2 minutes again. ठीक है, फिर हम वहाँ से next cases अपने करते हैं. Thank you, Dr. Yusuf. I hope you will stay with us. And हम जो है वो आप उसके साथ में एक दो cases और करना चाहेंगे. ठीक है.